Oh, they don't get to watch that over again.
Oh, here.
I'll do it again.
Hi.
Now it's recorded. How do we hit next? Just down there.
Okay, hold on. So,
Jaden, what's up?
right here. Okay. So just hit that button when you're ready. And
Is Jess, are you there?
I'm here. Can you guys hear
Oh,
me?
hi, bud.
Hola.
Okay.
okay, go for it.
Coming live from Mountain Green, Jess Carter. Okay. We have grapeseed extract. Marin.
Okay, so grapeseed extract, it's a dietary / herbal supplement. It's made by drying and pulverizing the seeds of grapes, and it's often done while making wine. So I just take the seeds out of it and get the extract from them, and it's full of antioxidants, including all the things. I'm not gonna read all those. It's like a ton of super good things. And there's grapeseed is often sold as an herbal supplement.
This is not the grape nut cereal, if you're confused, because that's what I thought it was. So the benefits of this, excuse me, I'm presenting right now. The benefits of this, they even out your skin tone. If you get really bad sunburn, you can put this stuff on, you'll feel like $1,000,000. They reduce your blood pressure because it improves your blood flow, and then which, causes healing to happen more quickly, and also can improve your bone strength. And then the ones on the other side, wound healing, it's because the blood flows better, reduce the risk of cancer. I feel like if anything claims that, you should use it immediately. Just, that's it. Don't even ask questions about it. Just take it.
Okay, so the history of it. So grapes have been used in medicine since the beginning of time. They used wine, but the grape seed itself has just recently become available for use. So this French professor, and if anyone speaks French and can say that, I think it's Vascular, something like that. Anyway, he extracted the antioxidants from the seed and turned it into something that people could use. And it's funny because if you look up the grapeseed oil to buy it, a lot of it is still branded under his name. It's Vascular's grapeseed extract. So he's a pretty big deal.
Okay, so recommended dosages. A ton of studies haven't been done on this, so a lot of things haven't been standardized. I found this on a pretty legit website for adults. Usually it's pretty legit. You want 90 to 150 milligrams is usually recommended for normal health maintenance. A higher dosage is usually used if you have a certain medical condition, such as high blood pressure, chronic venous insufficiency, or edema.
Oh, next. So the interactions, the biggest one that it said online is that grapeseed extract is not considered a blood thinner, but it does increase your anticoagulation, but it is not a blood thinner according to the CDC and someone else. But you want to ask your doctor before you take it if you are on any blood thinners, because it can make it worse. You could bleed out and die because of this. Not the grape nut cereal again. You can eat that just fine. And then also certain drugs in cancer treatments, which contraindicates if it is supposed to increase your chances of not getting cancer. They should have started it sooner.
Okay, and then you can take this in a tablet. It comes in oil, it comes in a powder, and drops. It seems like online the most common formulation of it actually was drops, and it looked like they were edible drops too. You could put them in your other foods and take it that way. And even if you're trying to prevent cancer, it's important that you don't take multiple formulations together. So don't be dropping them in the eyes and the ears and then snuffing the powder. You need to just keep them separate.
Okay, so if you're thinking, wow, I gotta get my hands on this stuff, where can you get it? You can get it in tablets on Amazon, GNC, Walmart, or other like herbal supplement websites.
I'm gonna get some.
You're gonna go get some?
Yeah.
Yeah, it helps you not get cancer. Side effects, you can get a headache because it increases your blood flow, folks. You can get itchy scalp, dizziness, nausea, and also you could get liver damage. So don't overdose on this.
So important things to remember, as with all of our other herbal supplements, it's important that you seek the advice of your doctor. They're going to be able to tell you if it has adverse reactions with things that you're already taking. Don't take more than the recommended on the label. Don't use the different formulations together. And it's important that you keep these stored in the sealed container away from moisture, heat, and light. Same with all your other medications.
Okay, so for our learning activity, I'm going to go ahead and read this for you guys. You are caring for a patient named Alice who is being treated for breast cancer. She has a history of diabetes and AFib and is taking medications for both. She recently started using grapeseed extract because her friend told her it could help her skin complexion. She has also been taking grapeseed extract tablets, thinking the more she takes, the better her skin will look. What are some concerns you may have after learning these facts about Alice?
Yeah, don't take too much, you'll have liver damage.
Yeah, toxicity.
I remember the name.
Thanks, bud.
I can't see the chat. Is anything in the chat?
No one's put anything in the chat yet. Oh, Dakota said possible overdose.
Yeah. Yeah. Pretty much that's it.
Olivia said liver damage.
Oh, thanks, Liv.
Might fix her breast cancer.
Yeah, she had to take it before. It prevents it.
I'm concerned about her choice of friends.
She has bad friends, so we need to call social work. Of course, we need to start an interdisciplinary team. Mark, you need to be your friend. If you guys are just dying to know more about grapeseed extract, there you go. Bye.
Okay, good job, good job.
I know, that was so important.
I know, that was way nice. Oh, I should have shared the screen. I didn't stop.
Dude, I watched the creatures from Black Widow, like last night.
This one might be a little different because it's a PDF.
And I sat there until I was late, and then you sat there, and I
So
was
you
about
reminding
to
like stop reading that.
So I moved to here, but then I was like, I don't want to be a person.
Okay, guys. Next up.
I'm white, so I can't see. So then I felt like, they should have brought some samples.
Really?
Yeah, right?
Woo woo. Okay.
Yeah, you do it CBD oil.
Mark, Alina, and Alina, sir. Okay.
You're the only one that shut up on your day.
Oops. Fernando, are you on too, my friend? Okay. Sweet. Okay. Okay, Mark, we're ready.
Did they need to chat?
Oops, sorry, guys. Sorry. Go back to the front.
Yeah, I
Where
didn't know
did you
whether
push?
to
Where did you push to open?
For what? Oh, up, just up here.
Oh, okay.
It's on the same.
Some old guy. Right?
Elena here.
Okay, go ahead, guys.
All right, guys. What is up, y'all? We're gonna do red yeast rice, and you know what that's about. I thought it was just normal rice, but apparently it's not. So
Before we start our presentation, I want to explain the activity real fast so you guys can kind of be thinking about it throughout it. We're going to do a separate page, so I'll just explain. So basically, we're copying Chantel. So throughout the presentation, just kind of think of your own nursing question and how you would ask a question about red yeast rice on the next exam.
Yeah.
Uh-oh.
I have pen and paper ready.
All right, guys. All right, so history. So red yeast rice was, if I can talk, was used first in the Tang Dynasty in China around 800 AD. If you guys have any idea when that was, but it was said to invigorate the body, aid in digestion, and revitalize the blood. So it was produced by fermentation of the mold Monascus purpuris. I don't know how to say that. So if you guys know, please put that in the chat or feel free to chime in.
So it's not rice at all?
It's yeah, it's mold. Yeah, check that out. So the general use of what they use for is like they use this a lot in Asian cuisine. So like Asian culture and for like flavoring and coloring and preservation of food. So it's like red, kind of like what it pointed out like at the beginning of the presentation. So the main purpose of this is because the yeast contains this thing called monocolin K, which is basically identical to the drug lovastatin, and then lovastatin decreases LDLs. And that is what we're going to talk about today. So that's exciting. And it's just shown, to just improve lipid and glucose levels also. Bless you. So this is considered a specialty supplement according to the FDA because of that. What is it? The monocolin K. The FDA has claimed it was an unapproved drug, so they sell it as like herbal supplements, like at just like markets and stuff. So they don't really it's not really supposed to be sold like on the market if it has the monocolin K. But the stuff they sell, like the supplements, are just have like the yeast in it, not the special monocolin K.
So for interactions with red yeast rice while you're taking it, it can possibly affect the muscle. So with any medications that do the same, such as cyclosporine, you just want to kind of be aware of the side effects since it'll exacerbate them. This also happens when you take drugs that lower cholesterol. Like Mark said, the monocolin K in red yeast rice is kind of the biggest active ingredient in it. So if you take it while taking other drugs that lower your cholesterol, it can also increase the risk of side and adverse effects, or just lower your cholesterol so much it's like dangerous. Red yeast rice can also be hepatotoxic. I can't talk, but it can also be hepatotoxic. So it can cause liver damage or just bad liver effects. So taking it with other drugs that also causes like acetaminophen can exacerbate that as well. So you just want to be aware of taking it with any drugs that affect the liver. It also has similar interactions with herbs that do the same thing. So herbs that are hepatotoxic, such as kava kava, it can increase the risk of liver damage. And grapefruit juice, like most kind of drugs, I feel like at this point that we've been learning, it can enhance the effect of red yeast rice, lowering cholesterol. And this also increases the risk of side effects and liver damage. And then this isn't really a herb or drug interaction, but I just wanted to good to include into that. Drinking alcohol while taking red yeast rice can increase the risk of liver damage as well. So you just want to be aware of kind of all these factors, the biggest one being the liver damage and lowering the cholesterol too much.
All right.
So when Steph asked if it is rice, it is and it isn't. So the yeast is grown on white rice, but once it's fermented, it's just kind of red yeast rice. It's kind of its own thing, like you said, it's like a mold. So it's fermented and it contains the active ingredient molecule K, like we've been saying. In China, it's mostly used in food preparations. It's kind of like more cuisine, like Mark was saying. But in the U.S., we usually only consume it in herbal form, which is like an herbal supplement, and that can be found by a medical provider that sells that.
All right, so conventional medical therapies, like kind of like I mentioned earlier, it just lowers normal LDL levels, but here in the United States, it is unapproved to do that. But on a study I found, the European Food and Safety Authority says that it can, if you intake 10 milligrams of the monocolin K in the red yeast, it's safe to maintain your normal LDL levels. So basically, you can't really take it here in the U.S. unless it's like a supplement.
All right. So the dosing of the red yeast rice, there really wasn't. There's kind of a stipulation here. The formulations in the United States don't really are allowed to have, like I said, any sort of molecule. I can't see the word molecule in K. In fact, they consider it anything that has high amounts to be illegal. But I guess this is technically what the therapeutic levels would be for the red yeast rice that actually does contain molecule in K. So for the high cholesterol and fats in the blood for hyperlipidemia, it's 1,200 milligrams to 2,400 milligrams of red yeast rice once or twice daily for up to 24 weeks, for what's recommended. Abnormal levels of blood fats in people with HIV or AIDS is 1,200 milligrams of a specific red yeast rice formulation twice a day for 8 weeks. And for heart disease, it's 1,200 milligrams of red yeast rice extract daily for about 4 to 5 years. Once again, yeah, it's considered illegal to actually contain molecule K in the United States. I guess because it's kind of a competition with statin. It also reacts with statin. And there's also a lot of, because of the way that it's manufactured, there's a lot of potential cross-contamination with red yeast rice. One of the contaminants in it is cytinin, which is, I guess, known to cause kidney failure. And there's kind of just different brands are just known to be avoided because of their poor quality and toxicity.
It's like both.
It's a fungus on the rice.
Yeah, and then they were the right rice and they used just the fungus to compile into the drug. Wow, look at that.
So yeah, due to the FDA regulations, red yeast rice products on the list are illegal. They're formulated in different types of supplements, and then other than that, most of the other cultures seem to just kind of consume it in a regular diet. You can see here a few photos of just kind of everyday foods, cookies, cakes, breading for different types of other foods. They really kind of just consume it any other way outside of the United States, and we don't get to.
All right. And that is it right there. That's us. Y'all should try some of that red yeast rice sometime. It's pretty bomb.
So then if you guys just want to discuss in class or type in the chat what you think would be a great question to ask, then for activity.
Kim got it.
Okay, so let's split all the flags.
Uh-oh.
Yes.
Yeah, that's what he said.
Easy select all the flags.
All right, I'm ready.
All right. Red rice has with the following. Identical to Loristan. Is that what the name of the
Hang on.
Yeah.
Lovistan.
What was fungus, and what was the other one?
Identical to Lovistan.
Okay.
Properties considered identical to Lovistan. Lowers LDL levels. Got that?
Yeah.
Hang on. Oh, I was like, she's
Oh.
pausing. I'm waiting for her to write it.
Sorry.
Contains vitamin K.
Okay.
I can see where you're going with that one. I got you. It's lower hyperlipidemia.
Okay.
Yeah. And then the last one is a type of rice.
Not the last three.
Yeah, nailed it.
A and B.
Yeah.
Basically, it's like the first three that are right. But you can move them around.
Also had a good one.
Oh, Brooke has one right there.
Ooh.
That's too hard, bro.
Yeah, Brooke, what the hell?
To avoid.
Do all that we
Avoid to avoid.
Kate,
That
that's so
wording
good.
too, so.
Yeah, I don't think. But can you expound on that?
She's going. Oh, no, she's not.
I think what she's saying is like select all the things that you need to avoid, like alcohol, grapeseed, lovastatin, right? All these things that you shouldn't mix with.
Well, they actually make wine out of the red yeast rice too. It technically can't be alcohol in itself.
They're hard then.
She
I
can
knew
hear
that
it.
actually.
Yeah,
I knew
it
that.
should.
Hey.
That would make sense. It's very aggressive.
Order some wine.
You good? Good
We're
job.
so excited. But not hard.
Very good.
Okay.
Her info message thing.
I was in Utah. We can't have it. Forgot I was in Utah. Yeah, bro. California.
You know
We
how
good?
I try doing that? I'll be like, I can do this, and then I'm like, Utah, you can't do that.
Yeah.
So frustrating.
Thanks. Join the wine club. Oh, you can't.
Yep, you can't. Actually, they'll let you join. They just won't ship
Yeah,
to
let's not
you.
ship to you. You can leave them at the border. I miss Bevmo.
All right, hang on here, guys.
You know what Bevmo is? Never do anymore. It's like Costco, but it's just.
Yeah.
Corby, Corby,
Is that what's that's right on a mesquite? There's
Corby,
one in
Corby.
Mesquite. No, what is that called?
How do I get
Oh,
my presentation
what's
into
his
Big
face?
Blue
Is it
Button?
Lee's Discount Liquor?
So it's like right there, but I want to be able to see chat.
Yeah, I was on Lee one time.
So you'd have to share your screen.
Is that the?
That's this one right here.
I walk in. And they have like buy one bottle of
So push it again.
for a cent. Type sales.
And then
So you're like
application
5
window.
pieces.
Yeah, for that one,
And then that one.
They were
And share.
Yeah, we told them about those deals. So we like came and looked at Trump.
I'm sorry.
And then do your slideshow.
You probably have to tell me that.
They have like all your different like
In the beginning, right?
like country. Oh really? Yeah.
Okay, and then that should populate.
That should.
Ralph's, yeah. Grew up. My grandma worked was like the seafood department first in her house growing up. I was there like all the time.
There you go. So now it's showing your screen.
It was like
Okay, perfect.
tell my mom like.
But to go to the next
slide.
slide, you have to hit that, like go back and forth.
Really? Oh my
Yeah,
gosh.
we don't have two screens.
Oh my gosh. Okay. So
Well,
can we-
okay, so here's another way. Sorry.
But yeah, they didn't get it till I was a little older.
You
It was like,
can
well, I think Albertsons is still there. I don't know.
upload it this way.
Or something.
Oh, okay.
Takes
That
a
would be
hot
really
second.
Dude, they have a remember Lucky? Lucky's grocery. They have one in
She's so
like
lucky.
in
This one?
Salt Lake, like South Salt Lake or something like that. Yeah.
Your
Upload.
like music generation is like way back today.
What?
Every song that Kim's been singing today is like old school songs.
I was rocking my like late '90s crunk list.
What do you know about Northgate, bro?
Northgate?
Yeah. You know anything about that?
Not much.
That's my store, bro.
Takes a hot second.
Anyway,
Yeah.
we're almost,
Look at my Jesus.
we're almost there. Yay.
Oh,
There you go. And then you can, this
Buy
red dot they see,
Okay.
that. Yeah.
And then that's where
and
you
then
do the
that's where you do
slide.
your slide.
Okay. All right. Can everybody hear me okay? This is where we, just so that the chat people. Okay. All right, great. Okay, everybody's having good. You can see the red dot, like a cat. You get to follow around, right? Okay, so let me set timer here. We are going to talk about vascular system drugs for hypertension. Are you all excited?
Yes.
Why not? What else I got going on today?
That's right. You had no better place to do than to be here in pharmacology. Okay, you guys recovered from the test? No, we don't want to talk about the test. Okay.
Remember.
You don't remember the test? Okay. We're still working on the averages because we have to. Okay, Shelby says she has a question. Okay, Shelby, go ahead. You have the floor. You're not dumb. There's no question that's dumb. No question that's dumb. Okay, what is it? Go ahead, put it on audio, Shelby. Can you? We can't?
Specifically talk, if it's a question about the test, we can't specifically talk about that yet because.
Is it about the test?
Did somebody not?
Yes. Okay.
Yeah.
So hang on, because we got to do the test and then we can talk about the test.
Shelby, email us or message us or text me or something.
Did you hear that? Okay. All righty. So here we go. All right. Here's our learning objectives. Okay. Again, review them. That's what the PowerPoints are based on. That's what the test questions are based on. I have to tell you, when I teach, I use a couple of words. And if I use them, you need to perk up your ears. You need to notate because these are important pieces of information. And the word is important. Important to know. Okay? And it's one of three things. It's either going to be generated as a great test question, or it's going to be something that you need to do or know in your nursing practice, that it's legit, that you'll see it every day, or both. Okay, so if I say something like, this is important to know, and I don't say that for every little thing, work it up. Okay, make sure you understand it. We good? Okay, so today we're going to talk about diuretics. So last week was all about the heart. Today, we're talking about vascular system, okay? So the vascular system includes the heart because it goes through the heart, but these are different kinds of drugs that affect the vascular system, not just the heart muscle. But because heart and vascular are connected, you'll see some similarities. Okay, so purpose of diuretics, this is important. What do they do? Wait. What's happening?
It's not changing.
It's not changing. How is it not changing here? I'm sorry. It's changing on Big Blue Button. I might have to go back to do all of that. Okay, sorry. We tried to make it easier. It's easier for the people online, but not for the people here. One more. Okay.
Oh, I don't have it on here.
On yours? Huh?
Ours doesn't have that information, like it just is blank.
Yeah, I see what you said.
Okay.
And that was, and you downloaded it this morning?
Yeah, just now. Like it has purpose of diuretics is peripherally HF, renal or liver disorder.
So you don't have number one. Okay, so I don't, you want to?
I would probably try downloading.
Try downloading it again because I just downloaded it.
Okay, so if you're not seeing this slide, try downloading it again. Online, are you guys having problems seeing it?
I see it on your screen.
Yeah, okay, everybody's no. Good. Thank you for chiming in. I appreciate that. All right, so if not, download it again. If not, write this down. Remember, I told you it's important. So the purpose of diuretics, there's two things. Number one is to reduce hypertension. Hypertension is classified as anything at 140/90. And it decreases edema. So it will do that peripherally. It does it with heart failure and with liver or renal disorders, okay? That's the purposes of diuretics. How it works is it increases urine flow by inhibiting. Remember, inhibiting means does not allow, okay? sodium and water reabsorption from the kidney tubules. And you'll see that there's a picture here coming up. So it doesn't allow sodium and water to go back into our system. It keeps it in the tubules so it goes out the urine. Okay. And diuretics can affect one or more segments. Wait a minute. Sorry. I don't know. How do we get rid of this? Of the renal tubules. And we'll see that in just a second. So now I have to go back to tab to do the next one. Or do I have to do both? This one, and then I have to go to back to, sorry, this one. Why did it? Oh, Barbie. Sorry, guys. Did this one. That one?
Yeah. This one. And then you change it here.
Okay. So I have to change it both places.
Yeah, unless you just want to share your screen, but then you can't see the big blue button.
Okay, and what do you do?
I just did this. I counted on you guys to tell me if anybody comments. I've gone back and forth too. It's up to you.
Okay. Do you want to do the chat? Do you want to keep the chat one up, and then that way we can address it, and I'll just do this one? All right. Is that cool? So continue with your chat, but we'll have here, this is what you'll see. Does that work? Okay. Does that work online? Are you guys able to move it to if I say next slide, then you guys can move it? Is that possible, or does that mess them up? So when I do this one, this is going to be the next slide here, but will that be in the big blue button also?
If you're sharing your screen, yes.
And I think,
But if you...
okay. So let me just ask this question, put it in the chat. Corby's going to maintain the chat. Can you see the slide that says review of related physiology and pathophysiology? I know all of you can. Online, can you see it? What are they saying? Or you can chime in if you have.
We can see it, Debbie.
Yeah, we can
Okay.
see it.
Thank you, thank you, thank you. Okay, so remember back pathophysiology, the kidney is a giant filtration system, and different parts of the kidneys have different sizes of screens or filters, okay? And depending on what kind of diuretics we're talking about depends on where it happens, okay? So we're talking about way up here. Can you see that? See where it says nephron at the top? That's where we're talking about. So it keeps it in there, and then it goes down into the calyx and the pelvis, which then goes out into the urine. Okay, you can also see the site of action. This is important. See the different sites where osmotic diuretics, down at the bottom, the loop of Henle. Isn't that great? I love anatomical names. The loop of Henle, the canal of Schlemm, right? Yeah. The sphincter of Oddi. Yeah, there's lots of different things. Okay, so it depends on where these drugs act upon the kidney as to what kinds of things they filter out or don't, keeping it in. Questions? Okay, yes, no? Okay, all righty. So there's 5 types of diuretics. You're going to need to know these types of diuretics, okay? There's thiazide and thiazide-like loops. So where do you think the loop might be? In the loop of Henle, yeah. Osmotic is going to be, sorry,
Just keep talking.
near the glomerular. Carbonic anhydrase inhibitors, where is that going to be at? It's kind of in the same place as osmotics. And then potassium sparing. What do you think that might mean if it's potassium sparing? Yeah, it's not going to get rid of it. It's going to inhibit the potassium from going out. I'm sorry, I'm really messing this up, aren't I?
You're fine.
Thank goodness we have Corby.
Hold on. Let's see.
Questions. So this is important. You need to know the types of diuretics.
Where would potassium sparing occur?
Okay, we're going to get to that, but potassium is going to be in the distal tubulars. Look at that. Go back to that one just a second. I'm going to put in a great one that's in your book. It's actually on page 552. So if you have your digital book, bring it up. If you have your actual book, turn to 552, because they actually in red show where these types act on and what they're doing, because you can see what the filtration system's doing of the kidney, what it's filtering out, and then what it's filtering back in, and that's where they're blocking it. Okay? What do I do now?
Just touch it, picture.
Oh, good. Like,
So.
yeah? Okay, I'm going to go to the next slide. And it should, this is your page 552. This is a huge, important picture to understand how thiazides work, and osmotics and potassium sparing. So let's take a look at it. Okay, do you see in red where they're acting upon? So someone asked potassium sparing. It's in the collecting tubules, okay? So it keeps potassium in, because most of the time that's where potassium goes back out, into the system. Because look where potassium goes out, which is in the loop of Henle, okay? So the loop diuretics, which is like furosemide, and we're going to get to that, is a potassium wasting drug. Go ahead.
I just want to make sure I understand. So potassium sparing keeps the potassium.
Yeah, keeps it in.
Get rid of it.
Right.
Okay.
Because most of the time, and we'll get to this in these drugs, most of the rest of these drugs, except the potassium sparing, they waste potassium. They get it out. And so is that good? Is that healthy? If you don't have enough potassium, what happens to the heart? Yeah, it gets really angry. And a lot of things happen because you need potassium. And so it gets irritable. So there are some drugs that hold potassium, okay? Because the loop diuretics get rid of them. So does the osmotics. So does the carbonic anhydrase inhibitors, okay? So does the thiazides. All of those get rid of potassium. So what does that mean you kind of have to have when a physician prescribes a diuretic that's not potassium sparing? What else does he have to prescribe? Do you think? A calcium supplement, yeah. Okay, questions on this? Online? Potassium, sorry. I know, you're like, oh my God. I'm sorry. And I didn't even bring candy. I promise I'll bring some stuff next week. It's like, reboot. Okay, potassium. All right, here we go. Okay, so this is kind of a little bit more in depth. Every 1.5 hours, the total volume of the extracellular fluid, this is fluid that's outside the cell, goes through the kidneys for cleansing. So small particles like electrolytes, drugs from glucose, waste products from protein metabolisms are filtered in the glomeruli. Okay? And so sodium and water are the largest filtered substances. These are, they go in and out. It's easy. This is the reason why the kidney can filter and go through a different part of the nephron, and it filters more things out, and then it allows water to come back, sodium to come back, as well as potassium. But remember, as goes water, as goes sodium, as goes chloride. Sodium and chloride like each other, and they love water. Okay, so if we're trying to get rid of water because it's edema, which is going to be which side, right side or left-sided heart? Right-sided heart. We want them to pee it out. Okay, so all these electrolytes kind of follow along. Questions? Are you getting it? All right. So here we are. 99% of the filtered sodium that passes through the glomeruli is reabsorbed. Okay, but we talked about it yesterday in the Q&A. You know, what happens when you eat a lot of sodium? Yeah, you retain it. Okay, and so what came first? You know, high blood pressure, heart failure, edema. Oh, somebody waving? Who's waving? Oh, okay. So this is important to know. Diuretics that act on the tubulars closest to the glomeruli produce the greatest natriuresis, which means it's the greatest amount that is able to get rid of. So in your opinion, based off of what that picture is on 552 and what this picture is here, what do you think the classes of drugs are the most potent? Okay, osmotics, you bet. Anything else? What's next? Okay, and those are in the same, yeah, that's in the same category. They're different categories, but they're in the same area. Okay, and then what's the next one? Loop. And loop and your thiazides are the most common ones that are prescribed.
What makes those more potent?
They're closer to the glomeruli. The glomeruli is where everything kind of filters, and then the rest of the nephron is kind of this in and out thing, helping to regulate blood pressure as well as helping to regulate fluid balance in the body. Okay.
It's better to have the one that's closer to the glomeruli than have them make prescribed thiazides if it's so far.
They actually do. And here's an important piece, and we'll get to it when we get to thiazide. Thiazide is the number one first line of pharmacology to for diuretics, as long as there's not any kind of underlying pathophysiology. So like they just have, they're not diabetic and things, and we'll get to that. But thiazides are prescribed quite a bit, and so are loops. Osmotics have some issues with them. They have to be really, really careful. So they're prescribed, but only in certain circumstances. Yes?
Where does the osmotics fall on this picture?
Right up here.
Oh, by the
Yeah.
carbonic one?
Uh-huh.
Okay.
Yep. Okay. So they have an antihypertensive effect because they promote sodium and water to get out of the body. That's called excretion, because they block the sodium from being reabsorbed. So if you don't have as much fluid in your system, what's going to happen to your blood pressure? It decreases. What happens when you're dehydrated? Does your blood pressure drop? You bet. Same physiology. Okay. So if you're losing fluids and you're hypertensive, is that a good thing? Yeah, it's a good thing. It helps lower. Remember, what's the purposes of diuretics? Lower blood pressure, get rid of edema. Okay. And the other, many diuretics cause the loss of other electrolytes. This is important. Potassium, magnesium, chloride, and bicarbonate, sorry. Okay, that's important. All right. Why do you think potassium and magnesium might be important? Okay, remember, everything is on a cellular level in the body. Mm-hmm. So potassium and magnesium are things that affect the heart. You don't need to know that. I'm just saying that's why it's important that you're not going to see this on a test. It's important in real life. If somebody's magnesium is really low from a diuretic, they're going to have problems cardiac-wise. All right, so here are the 5 categories again that are effective in moving water. Reboot. That are effective. All of the other diuretics are potassium wasting, with the exception of what? Potassium sparing. Exactly. Okay. Understand that concept.
All of these except for potassium sparing are potassium wasting.
Yes. Yes. So it doesn't matter where they're at. They all waste potassium, with the exception of potassium sparing. That makes sense, right? Okay. Most of the time, combination diuretics that contain both potassium sparing and potassium wasting have been marketed primarily to treat hypertension. So you'll see a lot of times that diuretics are prescribed with an antihypertensive medication. It's kind of a combo, because one medication, we'll get to antihypertensives, they act in a different way than what the diuretics do. And so you combine them to lower blood pressure. We'll get to that. Questions? Have I confused you? Okay. You want to write something down? Okay, so now we're going to start into thiazides while she gets caught up. And these are thiazide-like drugs, okay? And they act on the distal convoluted renal tubular. Go back to your picture on page 552. See where that distal tubular is? That's where they act, up on the top. It's like a little curvy on the nephron. Which is beyond the loop of Henle, and they promote sodium and chloride and water excretion. It's used to treat hypertension and peripheral edema. They also act directly on the arterioles to cause vasodilation, which also, what does that do? The blood pressure, when you dilate the blood vessels, it decreases it, okay? And that's the purpose. That's what we want it to do. These people have blood pressure or they have edema problems, which pushes up your blood pressure. Okay, it is not effective in immediate diuresis and should not be used in patients with severe renal dysfunction. So there's your contraindication on your thiazide. And your thiazide is one of your prototype, hydrochlorothiazide is one of your prototype drugs. That's important to know, okay? They have a longer half-life. So if you need fluid gotten off of the body like quick, you're not going to get a thiazide. You're going to get something else. Okay. They do cause a loss of sodium, potassium, and magnesium, but they promote calcium reabsorption. Okay. So if these over on the side, the serum chemistry abnormalities with thiazide, because remember, each medication has benefits and it has risks. Okay. So over here on the right-hand side are the risks. Okay. Your potassium is going to be low. We call that hypokalemia, right? Okay, and if it absorbs in calcium, then you're at risk for hypercalcemia, right? Too much calcium, okay? It also affects glucose tolerance, so hyperglycemia can occur, okay? Again, in your book, you've got stuff that on your thiazide, this is all explained, okay? This is not new information if you read your book. All right, hang on here. And on page 555, table 38.2 gives lab values. What is the normal lab values for calcium or potassium? You do need to be familiar with them, okay? Especially the potassium. That's important to know. Okay, 555, and I don't know what it is on the digital one, but on the book one, it's 555, 38.2. You need to be familiar with lab values. And so I need to reemphasize that thiazides are the first line of pharmacology to treat mild hypertension. Okay, it's the first line with no other underlying diseases. They simply just have high blood pressure. Okay, yes, go ahead.
With mild hypertension, you got 140/90.
Yeah, anything above 140/90. And we're going to get to actual classifications of what that means, like stage 1 hypertension, pre-hypertension. And that's going to be important to know. Because why do I tell you when things are important to know? Wink, wink. All right. So questions on this slide? No, yeah, we're good. We're still clear? We're hanging in there? Okay, this is where everybody goes, yeah. All right, so here's your hydrochloride thiazide, all right? Look where it says therapeutic, okay? It's an antihypertensive as well as a diuretic, okay? Because it helps bring the blood pressure down because it gets rid of, what are the two things? Edema and brings down the pressure, exactly. There's your mechanism of action, where it works, we just talked about. And adverse effects, we just talked about that. Orthostatic hypertension, need to know, what does that mean? What is orthostatic hypertension do you think it might mean? Yeah, when you go from a laying to a sitting to a standing, the body reorganizes and pushes more blood and pressure up to the head so you don't pass out. So orthostatic hypotension means that it hasn't had a chance to adjust. So this is huge. And when you're working in SNFs, it's huge when you're working in acute care, because what happens? You know, it's like, okay, we're going to get you out of bed, and you sit up, and then you stand them up, and what do? They faint, okay? Because they're like, whoa, I don't feel good, you know, and you have to sit them back down. Give them just a minute for a nursing guideline. Give them just a minute to adjust their blood pressure, okay? Then stand them up. All right. I'm not telling you anything you guys don't know. All right. Contraindications, important. What do you think the most important one is? Renal failure. Exactly. Thank you. And there's diabetes and gout, because it increases uric acid. Uric acid causes gout. And the most important thing here, dig toxicity. If your potassium is low, because remember, this does what to potassium? It gets rid of it. Okay, so if your potassium is low and they're on hydrochlorothiazide and they're also on digoxin, it increases their risk of dig toxicity. And that's important to know. Okay. And the nursing responsibilities, that's your blue boxes from your book. Be familiar with that with hydrochlorothiazide. Anytime you have a prototype drug, you need to know a lot about it. Okay. And they're all listed in the unit. So we can test on anything, but really concentrate on it. So why would you give in the morning? Why would you do that? Say it louder, Kim.
You don't want peeing all night. That's mean.
Yeah. Okay. Because they're going to do that. All right.
We do it anyways in the hospital.
I know we're so bad at when we give it. All right. So these are some combinations of drugs. We talked about, remember, we're going to do a diuretic with antihypertensive. This lisinopril hydrochlorothiazide, all across the board, as well as the amlodipine, the valsartan, and hydrochlorothiazide tablets. That has 3 different kinds. It depends on how bad the hypertension is, how bad the heart failure or the edema is how many drugs do you have to hit them. Now, you know, as well as I know, that when you go to clinicals, some people are on like 17 to 20 medications, okay? And so what they've tried to do is combine these, so you're just taking one pill that affects 3 things. And they're all individual, or they can be combined, okay? And so that's, just be aware, you're going to see that. So when you ask somebody, okay, and they say, well, I'm on lisinopril, you know, ask them, the lisinopril with the hydrochlorothiazide is lisinopril-HCTZ, hydrochlorothiazide, okay? And that's on their medication bottle. All right, so now we go on to loops, okay? They act on the thick ascending loop of Henle. So it's as the loop starts to go up. They inhibit the chloride transport of sodium. Sodium and water are lost, along with, and these are highlighted and bolded because this is important, potassium, calcium, and magnesium. That is important to know. It can affect blood glucose and increase uric acid levels. We just talked about that. So what are they more at risk for? Gout. So if they have a history of gout, would this be a good drug to give? Probably not, okay? That would be important to know. Drugs in this group are extremely potent and cause marked depletion of water and electrolytes. When given IV, and you don't need to know this, but that's the world that I live in, within 5 to 10 minutes, these people are peeing out the yin yang, like you wouldn't believe, okay? So, and they'll pee 800 to 1,000 mLs in 20 minutes, okay? And you'll see their blood pressures will come down. They'll start to breathe a little better, and things are getting better. So they're very potent. But what do you think's happened if they're peeing out 1,000 mLs? What's happening to that potassium? It's dropping. It's dropping. Yeah. So many times you'll see we give what we call a K rider, which is IV potassium. As they're peeing it out, we're trying to put it in so that the heart stays happy. Okay. It's more potent than thiazides for promoting diuresis. Diuresis means getting rid of the fluid. And they are less effective as hypertensive agents, okay? See the difference? This is when you say yes.
Yes.
Thank you. So here's furosemide. Furosemide is one of your prototype drugs. It is used a lot, okay? It's a diuretic. It's not used as an antihypertensive. It's strictly when you want to reduce edema and try and get the blood pressure down because of the edema. So this would be used in what circumstance, do you think? You just got tested on it. Heart failure. Exactly. It's going to affect the preload, okay? The stuff that's being backed up on the right side. All right, so there's your mechanism of action. Here's your adverse effects. It also affects anemia. So again, you kind of have to be careful with that. And if you give Lasix too fast IV for your RN, you can make them deaf, okay? It affects it that much. Deaf, D-E-A-F, deaf, deaf. Yeah. Sorry, I will try to enunciate my words. Yeah. I know. You can look at the contraindications. So if somebody's severely, hypokalemic, are we going to give Lasix? Yeah, no good, no bueno. Okay. There's the drug interactions and as well as nursing responsibilities. When somebody's on Lasix, they really need to be assessed as a falls risk. Again, because their fluid is markedly being depleted. Okay. Markedly. It's a big word. Markedly means high priority. Yeah, like fast. Yeah, like it happens fast. Yeah. And even if they take it PO, usually within 30 minutes, they start to pee. Okay. All right, so here we go to osmotic diuretics. They increase the concentration and sodium reabsorption in the proximal tubular and loop of Henle. These are the ones that are kind of closest to the glomeruli. And so these are the ones that you got to really be careful with these. Sodium, chloride, potassium, to a lesser degree, water are excreted. Excreted means gotten rid of. This group of drugs is used to prevent kidney failure and decrease intracranial pressure and decrease interocular pressure. And most of the time, that's what you will see these drugs used as. We used to use them a ton for head injuries in the ER to decrease intracranial pressure. There's other drugs that have a little bit better ability to do that, because what you're doing is you're shifting fluids, and then you decrease the head, but then you got all these electrolyte problems. So intraocular pressure, what do you think that might be a good use for? Glaucoma. Definitely. Mannitol is our prototype. You'll see that in just a second. And mannitol is used a lot in chemotherapy to kind of help, because you retain a lot of that in chemotherapy. So they use it to get rid of it, and it also decreases side effects of chemo. Whole different world. Yes.
Question. So where it says sodium chloride, potassium to a lesser degree, is that talking about just sodium or potassium?
Yes.
So potassium is not excreted as much as sodium and chloride?
Correct. It's still excreted because this is still a potassium wasting drug, but not as much as like your loop diuretic. Okay. But when you're shifting around sodium and chloride and water markedly, meaning like immediately and severe, you got to be really careful how this drug is used. And that's the reason why it's not routinely used as a diuretic. It's certain, they use it for what it's so much more effective at, which is decreasing intracranial pressure, intraocular pressure, as well as chemotherapy.
But if you're not excreting as much potassium using osmotic, then why would you choose the thiazide or thiazide, whatever, over this one?
Because of the adverse effects that this drug has. When you go back to risk versus benefits, it's too much of a risk in just simple mild hypertension or hypertension 140/90 to hit them with an osmotic, because it like shifts and shifts quickly and shifts a lot. It's not simply, we're going to inhibit the sodium and the water, from going back into. It's not that. It's like, boom, all or nothing. Yep. Okay. Yeah. So the side effects and adverse reactions include fluid and electrolyte imbalance. Okay. Do you want to really put your patient into a fluid and electrolyte imbalance like within minutes? Because they're better drugs. It causes pulmonary edema. and because of the rapid shift of fluids, okay? So the kidney's like getting it rid of, and so the body can't get rid of it fast enough. So what's it gonna do when it gets through the heart? It's gonna back it up into the lungs, okay? The left side, it's trying to pump, and the fluid has gone out, and it goes back into the lungs. So it causes pulmonary edema. No bueno if you have pulmonary edema, okay? Nausea, vomiting, tachycardia from the rapid fluid loss, and acidosis. So you see, these are some major things that this drug does. And so it's like, let's not be so aggressive here, okay, with it. Do you understand why this would be not the first line of choice, like what Kim said? It's the closest. Why wouldn't you use it? Does that make sense? Okay, so, and the problem is mannitol crystallizes, okay, and it can crystallize at low temperatures. And so you have to warm it before or you inject crystals into your patient. And it's not used in an IV solution if the crystals haven't been dissolved. This is just about the drug, okay? And it should be given with extreme caution in patients who have heart failure and heart disease or develop renal failure. So this is, again, one of the reasons why it's not as popular as thiazides, because thiazides don't cause heart failure, but this drug is not good for heart failure, people with heart failure. Okay? Go ahead.
Did you say it was like given to people who have cancer?
Yeah. But again, what I said, that's a whole different pathophysiology, and it's given to help the side effects of the chemotherapy. And because chemotherapy retains fluids, a lot of it very quickly, and so this kind of helps get rid of that in the chemotherapy. And if you have a head injury, and I know some of you guys work in ICU, the last thing you want is your head pressure, your intracranial pressure to be elevated. They put little things called burr holes, so they can monitor how much that pressure is, and they give medications to counteract that. Is that true? Yep, we're giving the thumbs up. Okay, so understand mannitol. The importance is decreases intracranial pressure, decreases intraocular pressure, and it's given in extreme caution. That's the takeaway. Okay. Carbonic anhydrase inhibitors, it's in the same place as the osmotics. They block the action of it, and which is needed to maintain the acid-base balance. So what do you think we're talking here? Acid-base balance, if they block it. You think you have things called metabolic acidosis, metabolic alkalosis. Okay, this is where that's shifting in. With prolonged use, metabolic acidosis can occur. The body doesn't like to be in an acidosis. Okay, this group of drugs is primarily used, and this is what's important, to decrease, what's IOP stand for? Yes, in patients with open angle, which is chronic glaucoma. Okay, important to know. Most of the time, that's what this is used for. Not for mild hypertension, although it does. It's mostly used to decrease the intraocular pressure, okay? It does diurese. They do use it in the management of epilepsy and in the treatment of high altitude sickness. So I had a patient one time that went scuba diving in San Diego, not like deep, just like, in the cove, got on a plane, came to Utah, had the bends really bad, which is high altitude sickness. Yeah, because he went down below sea level, and he went up high to sea level. He was a sick puppy, and we gave him this. And then guess what else we did? We flew him to the U, and they went into a hyperbaric chamber. Stayed there for a long time. Okay, hemolytic anemia and renal calculi. What is renal calculi? Kidney stones. Any of you have those? Yeah, no? If you're drinking a lot of pop, you will. If you don't drink enough water, you will. Okay, it's contraindicated in the first trimester of pregnancy. And it's contraindicated in narrow angle, which is acute glaucoma. Okay, that's important to know. Potassium-sparing diuretics, they act on the ducts. the collecting ducts, okay? And they promote sodium and water excretion. They get rid of it, and potassium retention to keep the potassium in, okay? These drugs interfere with the sodium potassium pump, and that is controlled by aldosterone, which is a hormone that's in the RAS system, that's part of the kidney. Remember RAS? Yeah, renin, angiotensin. Yeah. Yeah. All right. I know you're like, oh my gosh, that was 5 years ago. We're going to see it again. Yeah. Rastafarianism. Okay, these drugs are weaker than thiazides and loop diuretics, and they're usually used in combination with another diuretic or an antihypertensive drug. Because again, the purpose of diuretics is to what? Get rid of edema and lower blood pressure. So these are really good combination drugs. Potassium supplements should not be taken with this group of drugs. Why? Yeah, and too much hyperkalemia is bad as hypo. Okay. All right. Serum potassium should be monitored. That's part of your nursing guidelines. And these are used in cardiac patients to help keep the heart rate regular. So this is spironolactone. This is your prototype for your potassium sparing drug. Okay, it's a diuretic. Mechanism of action we've already gone over. We've already gone over the adverse effects, which is hyperkalemia. That's important to know. It also hepatotoxicity. We talked about the fact that it increases renal calculi, which is kidney stones, and you can get muscle cramps. It is contraindicated in renal failure. And if they already have hyperkalemia, you're not going to give this kind of a drug, okay? So you have to know what the potassium levels are. That goes back to that little box that I talked to you about, page 555. And and again, why would you give this in the morning? Exactly. Okay. That's important to know. Okay. So here's a question for you. Would loop diuretic and a potassium sparing be okay to take together? A loop diuretic and a potassium sparing drug, would that be okay to take together?
Yes, because it's passing. They equal each other out with the potassium.
Okay, say that louder, please.
They equal each other out with the potassium?
Yeah, exactly. Good thinking, right? One's getting rid of it and one's keeping it. So a lot of times you'll see, spironolactone used with a potassium wasting one, especially if they need more than just one drug to take care of getting rid of the edema and lowering their blood pressure. Okay, you'll see it used. But if this patient has kidney failure, would we use this drug with a potassium sparing or potassium wasting? No, it's contraindicated.
You would use them for either, right?
Yeah, it's no bueno.
So how do you get rid of fluid like that if you have someone who's got renal failure?
Well, again, it's individualized and it's dose related. That's on one of your slides, a few slides back. It's dose related. Your loop diuretics are dose related. Yeah, and if you kill your kidney, that's the reason why diabetics, a lot of them end up on dialysis. They kill their kidneys because glucose busts through the nephron, and over the course of years, those things can't be replaced. And so they don't. The kidney doesn't work. And so dialysis is an artificial means of filtering the blood that the kidney would do. Does that make sense?
Mm-hmm.
Okay. Questions? Okay. Let's take a 5-minute break. Does that work? All right. 7 minutes? 7 minutes. All right. 7 minutes. Good job. Your glomeruli is functioning.
Oh, they're kicking.
All right. So let's see. What do we do? Pause. Are there any questions from the chat? No, I'm talking to the people on the online. Okay. I'm just looking here. Okay. Has this been straightforward and you understand at least what we're talking about?
Yeah.
Okay.
Shelby says we do.
You're going to have to read your book, guys. You're going to. And you're going to have to break down these 5 areas into what do we do, what is not good in this situation. I've given you several important things to remember.
I think my book, because it's the downloaded version, doesn't pull over everything that the physical book has. Because I was looking at it compared to someone else's, and I'm like, oh wait, I don't have this chart. Oh wait, I don't have this.
Okay. So they do have, okay, I don't know if you heard, Kim said that the digital version she feels might be different than the actual hard book because it doesn't necessarily bring everything over. You do have student resources. And if you go onto student resources, it has animations, it has little videos, it has test questions that are like practice. It has important keys. Like this lecture came from the key points in your book. Okay. All righty. We're going to take a little break here. So I'm going to pause it. Is that what I do? I'm sorry. I'm still learning. To the top right there? Okay. So we're pausing. People that are online, we're pausing. Pause recording.
I can still see you.
Okay.
It's just not.
It's just not recording. Say yes? Okay. I'm sorry, guys. Steph, do you want to check on her? Make sure she's good?
Right, I'm sure she's fine.
I mean, yeah. I mean, if you hear weird noises, don't, do anything. But we just want to make sure everybody's okay. All righty. Okay, so we're going to start again. We're now in chapter 39. Antihypertensives. Okay, we good? We're ready? Is everybody back with us? Let us know online that you're back. I did push record. Do you want to check and make sure I did it? Because I don't want to be... Okay. Yay! I'm getting things here. Okay. Alrighty. Let's get started. I'm waiting for conversations to end. Okay. Alrighty. So let's get back to our delightful slides. Okay, hypertension. So there was a question in the back, like, is this hypertension? Is this pre-hypertension? Yeah, this is where this comes in, okay? So it's classified as greater than 140/90. We're actually gonna break it down a little bit more. And so there's 2 classifications. One is called primary. It's also known as essential. This is the most common. It affects 90% of people with hypertension. They don't know why. The origin is unknown, but there's numerous contributing factors. Some of that includes age. As you get over the age of 60, you have a higher, in fact, I think it's like most 60% of people have hypertension by the time they're 60. So some of it's age-related, some of it's genetics, some of it's lifestyle, and we'll get to all of that. Worldwide, 1 in 3, okay? So hypertension is a huge thing globally, okay? All righty, these 5 concrete steps help prevent high blood pressure. And this is where we get into, and there's a whole nother slide on non-pharmacological things, but this is where non-pharmacological things assist with pharmacological things. So that's your healthy diet, your physical activity, avoiding tobacco, avoiding harmful use of alcohol, managing stress, and that includes caffeine, guys. Okay, the other part is secondary hypertension, which is 10%, and that's related to renal and endocrine disorders, okay? Hypertension is the most common condition leading to myocardial infarction, which is also known as an MI, which is also known as a heart attack, stroke, renal failure, and death, okay? It's called the silent killer because most of the time you don't have any kinds of symptoms that says, oh, I need to go to the doctor, I'm not feeling well, okay? And they go and they're like, your pressure is like 180/100, and you're like, what? Yeah, okay? It's a silent killer. All righty. So here's the guidelines for our people. This is important to know. The purpose of these guidelines is to decrease the risk of cardiovascular disease in the American population. Okay, so normal blood pressure is less than or equal to, remember that from math, less than or equal to 120 over 80. Pre-hypertensive is 120 to 139 for systolic. Hi.
Hi, Vicky. I'm on the other side, sorry.
And diastolic between 80 and 89. Now, and then stage 1 is 140 over 90 to 159 over 99. Stage 2 is 160 over 100. Here's the caveat, guys, and this is what's important to know. Your systolic pressure has a greater weight in terms of what classification you go into than your diastolic. Some of you may already know that, okay? So if you have a pressure that's 150 over 82, where would they be in this classification? 150 over 82. Why? Why are they stage 1? I'm not disagreeing with you. Tell me your answer. Yeah, because your diastolic, if it's 82, where does that fall into? Pre-hypertensive, okay? But the systolic is over 140, which puts them in stage 1. Remember, that's what I said. The systolic pressure has greater greater importance than the diastolic. Does that make sense? Are we clear? That is important to know to understand that concept.
For exam.
I just can't see because your head.
Oh, I'm sorry. Sorry, I have a big head. The perfect angle that I was blocked, and I do take up a lot of space, guys. I know, and it kind of ticks us off that they didn't do this, and I'm like, why would they not? It's like, or they needed to move this screen over, but yeah. Alrighty, here we go. So this is where your non-pharmacological control of hypertension comes in. Okay, a significant decrease in blood pressure can be accomplished by non-pharmacological methods. Okay, so in fact, Corby, weren't you saying something like the increases of heart attacks? The increase how much? How much percentage after the elections?
It just said a significant increase
in
cardiovascular events.
Yeah, cardiovascular events, which is like heart attacks after a national election. Go ahead.
Yeah. The increase just in Utah, the study of MIs was 27%.
Yeah.
They found.
Yeah.
I thought that was.
Yeah, it is because it's stress. So if you can do stress reduction techniques like yoga, meditation, that's going to reduce the stress. Okay. Yoga's good. Exercise, salt restriction. Did you guys remember we did a Q&A, yesterday, and I said, hey, when you're eating stuff, just take a look how much sodium it is. Corby hadn't eaten at all, and so she went and got some ramen. How much sodium was in there?
So what?
It's just one package of ramen. It was 1,600 milligrams.
One package of ramen, which how many packages of ramen do you guys eat at a time, right? One was 1,600 milligrams. Okay, maximum amount is supposed to be 2,000. Okay, so she blew her sodium intake for the day with the ramen. Okay, quit smoking and reduce caffeine. Okay, yeah. All right, both non-pharmacological and antihypertensive meds should be combined to control hypertension. That's important for you to know for patient teaching, okay? So it's not just the drugs, it's what can they do to modify their lifestyle. Okay, if the systolic pressure is greater than 140, antihypertensive drugs are generally ordered, okay? All right. So pharmacological control, this is where, Kim, we get an individualized approach, okay? Everybody's different, and so your dosages are going to be different and your combinations are going to be different. And that's going to fall to those people with the MD behind their name, More than one antihypertensive is used, which may lead to fewer adverse effects, okay, if you're just having one. These are the classifications of antihypertensive drugs. And each one of these will have a prototype and a medication that, represents that class, okay? All righty, here we go. So selected regulators of blood pressure. So the kidneys and the blood vessels strive to regulate or to maintain a normal blood pressure, and they do it by fluid volume and by the RAS system. Okay, this should be, kind of coming back to you, okay? The renin and angiotensin aldosterone system is what RAS stand for. Okay, kidneys regulate it by the RAS. Kidneys control sodium and water elimination and retention, right? We talked about the diuretics that do that, keep it in, inhibits it from going back. So we also have some baroreceptors that are in the aorta and in the carotid sinus and the vasomotor center in the medulla that also assist in the regulation of the blood pressure. So this is where, baroreceptors are picking up and saying, wait, we need to raise blood pressure or we need to lower it. And the medulla goes, oh, okay, yeah, I got that and we'll do that, okay? So that's, again, this is the vascular system, okay? So these are things that, God or the universe or whatever you believe put into the body to be able to say, okay, let's keep us at the normal level, okay? So norepinephrine and epinephrine increase blood pressure through vasoconstriction. And they actually have drugs so there is a norepinephrine drug, okay? We use it in the ER all the time with people who have no blood pressure because this drug constricts the activity and increases the blood, okay? But you have norepinephrine and epinephrine in your body already that do that. So again, it goes back to the pathophysiology of when something's out of balance, when the body's not doing well in a certain way, the medications come in to kind of bring it back into homeostasis is kind of what we have to. You'll see this again. All right. We're good? All right. So this is extremely important. This is the RAS system. This is the photo from your book. It's on page 564. Okay. It's totally important to know. So you have the renin from the kidney, the angiotensin from the liver, and the liver secretes angiotensin 1, which is a weak vasoconstrictor. Do you see the little arrow there, the red arrow that says angiotensin converting enzyme? ACE. And do you remember the groups from the thing before? One of them was an ACE inhibitor, okay? So inhibit means to not allow. So what do you think these drugs, ACE inhibitors, are going to do? Okay, they're antihypertensive because what are they blocking? Yeah, they're blocking into the RAS because if they don't, then it converts it, angiotensin 1 converts it to angiotensin 2, which is a very potent vasoconstrictor. And an angiotensin 2 receptor blocker is also known as a ARB, and that's where that's affecting it, okay? So again, it depends. Truly, the most brilliant people in medicine are the chemists that are developing these drugs, okay? Because that's what they're focusing on, these little things, okay? Because if not, then angiotensin converts to aldosterone, as well as peripheral vasoconstriction. If you're peripherally constricted, what do you think your blood pressure is going to do? What do you think? Online? What do you think? What's it saying, Corby? Nothing? Yeah, it's going to go up, okay? You constrict the blood vessels, the blood pressure goes up. You dilate the blood vessels, what happens? Blood pressure goes down, okay? Every day, in and out, all the time, And that's actually happening in you right now. You just don't realize it. That's one of the reasons, like when you take a blood pressure and it's like 132/80, okay? And then you take it 5 minutes later or 10 minutes later, and it's 128/82 or 84. You take it a little bit later, it's 140. That's because the body is doing this, okay? And so your blood pressures are going to vary a little bit because of what the body's doing, and as well as whatever medication you're giving them to decrease it. Does that make sense? Okay. All right. So if aldosterone is released, that retains sodium, which affects blood pressure. And it also affects water retention, which restores fluid. That's what happens when you go from a laying to a standing situation. This system is in place. So are the baroreceptors, and it shoves things around to keep pressure to your head so you don't faint. All right. So, what?
Cute.
I know, isn't it? Corby's awesome. This is her slide. I wish I could take credit for it. I can't. She's hilarious. And yeah, so isn't that great? A diuretic, are you sure about this? And they're snowmen, right? So diuretics are used to treat mild hypertension, right? We went over that. It's often administered together with other antihypertensive agents. We talked about that. Refer to page 565 and the previous chapter that we just went over. All right, so then the next one is sympatholytics control of hypertension. So these have 5 groups of drugs, okay? The beta-adrenergic blockers, okay? Centrally acting alpha-2 agonists, alpha-adrenergic blockers, adrenergic neuron blockers, which block peripherally, as well as alpha-1 and beta-1 adrenergic, okay? So remember, alpha or beta-1 and beta-2, what's beta-2? Lungs. What's beta-1? Heart. So alpha-1 is heart. Okay? So if you have an alpha-1 and a beta-1, it's selectively targeting hypertension that's coming and affecting from the heart. Okay? So we're going to go through all these groups. So you can see this little diagram over here on the side, and it has to do with the heart. It has to do with widening the blood pressure, or widening the blood vessels, and it has to do with interactions of the kidneys. Okay. Let me just give you a couple of information so you might want to, like the ACE inhibitors. So going back to that, let me go back to, hang on, to this, the pharmacological control. ACE inhibitors, I put up a picture of the last names of the drugs. It's in the study helps, okay? In ACE inhibitors, most of the time, the last name of the drugs will be PRIL, P-R-I-L, okay? So when you see something with a PRIL, that's going to be an ACE inhibitor. ARBs have the word sartan, okay? Yeah. And so that is important, okay? Norepinephrine, remember we talked about norepi, or norepinephrine. Okay, they work on the catecholamines that constrict the bloods. Okay, that's important. If you have a constricted blood vessel, your blood pressure does what? Increases. So blocking norepinephrine is going to do what to your blood vessels? It's going to decrease it. It's going to make them smooth. That's part of the mechanism of action for hypertension. And I will tell you, the mechanism of action for hypertension, you need to know well. Okay? All righty. How does the body and how does medications work? The mechanism of action to reduce hypertension. All right, let's go into beta blockers. You know some of these beta blockers, right? What do you know about beta blockers? LOL. Yeah, they are. So their last name is LOL. OLOL. Okay. Yes, they are going to. Okay. So let me go back just 1 second here. Let's go back to this. Okay. So, right, exactly. And that's right. So you have to be really careful with COPD. Yes, Corby teaches a lot. Okay, so let's go back to this sympatholytics, control of hypertension. Okay, so when you talk about the sympatholytics, okay, that's all kind of in that group. Okay, they block the actions of the catecholamines. The smooth muscles are going to do, in the blood vessels, what are they going to do if you're blocking that? They're going to relax. Yeah, they're going to relax and dilate. Okay, that's going to lower the blood pressure. The peripheral resistance, how hard is it to get through these blood vessels peripherally? That's going to be lowered. And also diuretics, because remember diuretics was part of how you control high blood pressure. What do? They don't let sodium.
They don't let it leave. They hold on to sodium. It pees out potassium, holds on to sodium.
It don't let sodium go back in. Because remember, sodium follows water. So they inhibit sodium absorption.
No, water follows solute.
No, so sodium follows water. Water has a huge positive ion and it attracts. It says, come to me. And so sodium chloride loves to come to water and hold on to it tightly.
There's your water retention.
There's your water retention.
The sodium holds on to the water.
Yeah. So again, as goes water, as goes sodium. What?
Everything I know is a lie. I quit.
Kim is having a meltdown. It's okay. All right. So beta adrenergic blockers diminishes the sympathetic nervous system. It reduces heart rate, contractility, and renin release. Renin is from where? Kidneys. And so you get hypotensive response is greater in patients with high renin levels. This is really important. This is where Black Lives Matter. We're going to talk about Black Lives Matter today. All righty. African American hypertensive patients do not respond well to beta blockers. That is super important to know. In your nursing practice, it's super important to know. So it's just genetics. You can't run away from your genes, guys. And for whatever reason in their DNA, they don't respond well. Asian people, they are 30% more sensitive to beta blockers than white people. Okay, what is it? It's just their DNA. Okay, you don't have to know that for the test. I'm just saying, Black Lives Matter. This is important. Beta blockers don't do well alone. So in a Black person, if they had hypertension, if they were giving a beta blocker, what would you expect to see?
Nothing really. Not as effective.
Not as effective. So what would need to happen for them to get lower blood pressure? Thank you. Say that louder. Exactly, a combo meal. Exactly, a combo of a different drug. You guys got to tell me who's coming by. Oh, Annie. Okay, so there's many types of beta blockers. You guys said this that we're here in class. There's non-selective. You had that, propranolol and carvedilol. They're very common drugs. Cardioselective is metoprolol. That's going to be your prototype drug. Atenolol, acetobutolol. You see the lols? Right? Okay. Beta blockers should not be used by patients with second or third degree heart blocks or with those that have bradycardia. Why do you think that? Why would that be a true statement?
It resloads your heart, yeah.
Okay. Did you hear that online? Are they saying anything? Okay. And then here is where it comes non-selective, which is beta 1, beta 2. It's non-selective. Selective is beta 1. Or high doses of selective should not be given to a patient with COPD. Why do you think that is? You already told Corby. Say it again. Let's do it online. Somebody online tell us why that would be a true statement. And Corby will say it.
Oh, I see.
Online, I need you to respond. Wake up.
They're saying that it's hard to hear the people in the class. So if it's something that the people in the class are saying, you
Okay.
should probably repeat it so they can hear it.
All right. So, Kim,
Yes, ma'am.
can you repeat it with your mask down and a little louder? And then I'll repeat it too.
Okay. So a non-selective beta blocker is going to
Hang
target
on. A non-selective beta blocker is going to target
the lungs,
the lungs
as well as the cardiovascular system.
as well as the cardiovascular system. Okay. So COPD is a disorder of what?
Cardiovascular, the lungs.
The lungs.
Sorry.
Okay. So if you have a non-selective or you have a high dose of selective, it's going to affect people with COPD. Clear as mud? Here's metoprolol. Okay. Okay. So metoprolol, this is an anti-anginal or anti-anginal, antihypertensives and antidysrhythmics. That's its therapeutic uses. So this is where your combos come in, okay, your combo meal. And it promotes blood pressure reduction via the beta blocking effect. I've lost there we are. Adverse effects, don't give it if you have a heart block. We've talked about it, or bradycardia. That's important to know. Contraindications, cardiogenic shock, acute heart failure, bradycardia, caution with COPD. We've talked about that. Drug interactions, it will increase bradycardia and heart blocks with digitalis and clonidine. We're going to get to clonidine in just a minute. I know. And it increases with alcohol and other antihypertensives. And this is where NSAIDs decrease the effect of beta blockers. So if somebody has a headache, are you going to tell them to take ibuprofen or Tylenol?
Tylenol.
Anybody that's on an antihypertensive medication, get them to Tylenol, not NSAIDs. All right. So for nursing, what do you think you need to do to monitor and to keep the patient safe?
Blood pressure.
Yeah, exactly. Vital signs, I&Os. All right. And daily weights. Okay. Here is a little caveat. Each liter of fluid is 2.2 pounds. Okay. So it is not unusual for over the course, if somebody has come in because they've got congestive heart failure, they've got hypertensive urgency, and they're in a crisis, it is not unusual to take off 10 to 20 pounds while they are in the hospital over a 3-day period of time.
Yeah, right.
I know. Wouldn't that be great? Wouldn't it be great? Except what's their hypertension coming from most of the time? Heart failure. And that is not a good thing to have. Okay. And monitor for compliance. This is huge because you'll ask them, do you have any medical conditions? And they're like, no. And then you ask them what their medications are, and they say, oh, I take metoprolol. Do you have high blood pressure? Well, yeah, but no, because I'm on medicine for it. They think they don't have the condition because they're on the medicine for it. And then they think, oh, well, I only need to take it if my blood pressure is high. Because part of compliance is taking your blood pressure. Oh, well, it's a little higher, so I'll take it today, but I won't take it tomorrow. Oh, not good, not good. Yeah, wonder why your pressure is 200 over 110 because you haven't taken it for 5 days. All right, centrally acting alpha-2 agonists. Agonist means it increases it. But it works by decreasing the sympathetic response from the brainstem, right? The vasomotor from the medulla, okay, on the peripheral vessels. So alpha-2 receptors are stimulated, which decreases the sympathetic activity, which increases vagus activity, decreases the cardiac output, decreases the serum epinephrine, decreases norepinephrine and renin release. And what's it going to do to those blood vessels? It's going to help lower it. Yeah, it's going to dilate it. It's going to make them more relaxed. That's important. Relaxation allows the blood pressure to come down. Okay, and the drugs in this class is called clonidine. Given frequently with diuretics. Okay, this is one of those combo drugs, the combo meal. And it is available in a transdermal patch that provides a 7-day duration of action. We get this a lot in detox, okay? People come in detoxing from opiates or from alcohol, and their blood pressure is through the roof, okay? And we will put a clonidine patch on them. If we can't get them into treatment and they're not sick enough to stay in the hospital, we put a patch on them. The same things occur. Where are you going to put the patch? What are you going to do? Your date, time, initial has to be clean. Where is it going to be? Yes. Yeah. Okay. Side effects include drowsiness, dry mouth, dizziness, bradycardia, peripheral edema. Should not be stopped abruptly. What do you think is going to happen if you stop central acting alpha-2 agonists? Yeah. Reflex what? Reflex, rebound, what? Hypertensive. Okay, so you're trying to decrease it, you abruptly stop it, what's it going to do? It's going to shoot up, okay? Blood pressure is going to shoot up. All right. So wait a minute, okay, the third group, alpha adrenergic blockers. They block the alpha receptors that result in vasodilation and decreased blood pressure. They help maintain the renal blood flow rate. They're useful in treating hypertension in patients with lipid abnormalities. That's important to know, okay? They decrease, you're going to go through lipids in the afternoon. They decrease the VLDL, which is no bueno, and the low density. They increase the high density. It's safe for patients with diabetes because they do not affect glucose metabolism. Remember, we've talked about that. Some of these other drugs affect glucose. So this is a good one for that. They don't affect respiratory function. Yes? Okay.
If it says it's just the alpha, do you assume it's alpha 1 and alpha 2?
It will, that's a good question. It's selective. Remember, alpha 1 is cardiac. Okay, alpha 2 is the alpha. Okay, let's go back. Hang on. Okay, centrally acting alpha 2s. Okay, clonidine. Yes. So the question was difference between alpha 1, alpha 2. Alpha 2 is clonidine. Alpha 1 is going to be the prazosin. Right? Is that correct, Corby? Corby's checking it.
Fact check. Yeah.
Okay, that's true.
That's that weird one. Alpha 2.
And your second question?
What is a lipid abnormality?
Lipid abnormalities. Okay, abnormalities mean not normal. Hyperlipidemia is high cholesterol, right? So you have high lipids in your blood. So these are lipid abnormalities. These are when those lab values are out of alignment of what normal is. Lipid is a fat, right? So this is fat in the blood. So just a side story, and some of you may have seen it, especially if you're in phlebotomy. If you draw blood on a person that has high lipids and they spin it, it spins the fat out. Have you seen it? Bring it up an image. Bring up an image on your Google, and they can't test the plasma because the fat molecules are in the plasma. It's a huge issue. And something?
Yeah, just to clarify on this, so we're really talking about cholesterol specifically imbalanced on the labs.
So the alpha adrenergic blockers, which is prazosin, help with lipid abnormalities. So if the patient has high cholesterol or some sort of a lipid abnormality, this helps with that as well as decrease the hypertension. Because remember, hypertension can be caused from vasoconstriction or what's underneath, the plaque that's causing the vessel to be narrow.
I guess my question was, what other labs besides cholesterol are indicating fat?
For prazosin?
No, not meds, labs.
So that's going to be your VLDL, your LDL, and your HDL. Those break down the cholesterol. So cholesterol is like one number, but you break down cholesterol into VLDL, HDL, and LDLs. And those all have normal values. Does that make sense?
Yep.
So it's not just important to know that, your cholesterol is below 200. It's even more important to know what's your VLDL. because that's the very bad stuff. So you can have a normal cholesterol and really bad VLDL. Does that answer your question? Okay. So prazosin, I call it prazosin. What did you call it? Prazosin. Yeah, it depends on where you put your accent. So this is a selective alpha-1 adrenergic agonist, okay? What is its therapeutic? It's antihypertensive, okay? And what's its mechanism of action? This is on vascular smooth muscle in the arterioles and the veins. So this reduces the resistance, the peripheral resistance of how we're going to lower blood pressure. And it's selective on the alpha-1. Okay, adverse effects. Again, you have your orthostatic hypertension. Any of your patients that's on a diuretic or a combination of diuretics and antihypertensives, you've got to be on the lookout. This has to take high priority of orthostatic hypotension. All right, so contraindications. Here we are. Hypertensive drugs, other hypertensive. Oh, wait, sorry. Yeah, okay. Because part of the adverse effect is that it creates or promotes erectile dysfunction, okay? So drugs that are, that affect erectile dysfunctions like nitrates, you can't use. You can't use because they're at odds with each other. And this is one of the reasons why a lot of people don't like this drug and they don't like to take it and they're non-compliant because it's all about sex. All right. It's all about sex. Okay, drug interactions. We talked about that. And again, decreased effects with NSAIDs. So anybody that's on a hypertensive, shoot them over to Tylenol. Keep them away from ibuprofen. Okay. You need to assess the first dose for an orthostatic reaction, dizziness and weakness, and syncope. Monitor your eyes and nose, monitor blood pressure, and assess for BPH, benign prostatic hyperplasia. That's the enlargement of the prostate. Okay, you guys have been passing off holy caths. It's like I gave you some important things to do, like if you run across resistance, like just get the penis, put it into first gear. So like raise it up and it'll be able to go around them. I know everyone's like, what? Okay, here, fourth class, adrenergic neuron blockers. I like neon. Okay, these are potent antihypertensive drugs that block norepinephrine release from the sympathetic nerve endings that result in lowering the BP. So sympathetic nerve endings, where do you think that might be at? Peripheral, yeah. Cardiac and peripheral resistance is decreased, okay, which lowers the blood pressure. It allows that resistance to be decreased, so the blood flows a little easier. Okay, this drug, risperidone, it can cause vivid dreams, nightmares, suicidal ideation. Do you think it's used a lot?
No.
Yeah, because those are side effects of it, okay? And orthostatic hypotension is a very, very common side effects, okay? It is considered the last resort. When nothing else will work, they will use this, okay? And it can cause sodium and water retention. You don't want that because does that increase blood pressure?
Yeah, it does.
Yeah, so, I mean, it's a drug that works, but not very well. All right, alpha-1 and beta-1, adrenergic blockers. Page 572 in your book explains this better. If you have questions, and again, you need to go to there, okay? To 572. Labetalol is a example. This was my first time of an OSHIZ moment where I realized I had in my hand the ability to kill a person. I was PN2s. No, I was RN3. I was RN3, and I was in ICU at McKay. And this patient was having a hypertensive crisis, and the intensivist ordered labetalol, and he ordered a large amount of labetalol because this dude's pressure was like 280 systolically. I thought he was going to like blow apart his fourth ventricle. Anyway, so we had like 220 milligrams, which is a huge dose. 300 milligrams is like the maximum. And so as I was talking to my nurse, he's like, so how do you give this? It's an IV. And I said, well, Okay, so it's acting on the alpha 1 and the beta 1 cells in the heart. I know it slows down the rate, but if I give this too fast, what can I do? And he said, you will kill the patient if you give it too fast. Okay. And I was like, I don't think I want to be a nurse anymore. Just tap me out, And so this is the reason why it's important to understand these medications, because especially when you get into RN, okay, and you start adding IV on top of this PO stuff, it's a whole new ball of wax. Okay. And large doses increase the airway and airway resistance. Patients who have asthma should not take large doses of labetalol. So do you think that the intensivist had to see his medical history? Yeah, and he didn't have asthma. That's why it was prescribed. Okay. Side effects, orthostatic hypotension, dry mouth, and fatigue. And direct acting arterial vasodilators on page 573. They relax smooth muscles. Again, what happens in the mechanism of action to decrease blood pressure when the smooth muscles relax? What happens to them? They dilate. Okay, this is the same thing. I've said it 6 different times. All right, and that helps decrease the blood pressure, and it promotes an increase in blood flow to the brain and kidneys. Diuretics can be given to decrease the edema. There's a couple of them that are used. Hydralazine is used for moderate to severe hypertension. Okay, they'll take that PO. Most of the time you'll see it IV. And then nitroprusside is given for acute hypertension emergency, and that's where you live. If you're in the ER or ICU, we will give this. In fact, we give icardipine, which is it's the same class, just different name. Okay, and it causes little orthostatic hypertension because they dilate the arteries, the arterioles. Beta blockers are frequently prescribed with this to decrease the heart rate. Side effects can be numerous, which include reflex tachycardia. You'll see that a lot. I see that a lot. When I give hydralazine, it slows it down and then it comes right back up, just like bounces right back off. Reflex tachycardia. Nasal congestion, dizziness, it can cause GI bleeding and neurological symptoms. So those drugs are given carefully. This is where we get to live in ACE inhibitors, okay? Remember, we talked about ACE inhibitors, the angiotensin converting enzyme, it inhibits it. It doesn't let it convert it to angiotensin 2. Okay, and page 573 to 576, it does not allow the formation of angiotensin 2, and it blocks the release of aldosterone. If you block something up at the top, what happens to the tree? Yeah, it's going to affect the whole tree. So, and it can cause a little change in cardiac output and heart rate, but they lower the peripheral resistance. Again, that lowers blood pressure. And they're used primarily to treat hypertension, and some can be effective in treating heart failure. What do they end in? Pril. Okay, pril. ACE equals pril. Okay, and lisinopril is going to be your prototype. Here's our Black Lives Matters. African Americans and older adults do not respond to ACE inhibitors with the desired reduction in blood pressure. Usually they have to have another, the combo meal. I'll take a number 3 combo meal. Should not be taken during pregnancy because they reduce blood flow to the placenta. It should be taken with food. So there's your patient education. There's your nursing guidelines. Primary side effect is a constant irritated cough. People that take Prils always have a dry, well, not always, but like I'd say 99% will have a dry, non-productive cough. They're just always, and then they'll go, okay? And it can be relieved by either substituting a drug, that's important, but it should not be taken with potassium-sparing diuretics. Okay, if that's the case, what does that tell you about ACE inhibitors? What does it do with potassium? Yeah, it holds on to it. And so if you take a potassium-sparing diuretic, which is also known as, but there's only one, spironolactone. Yeah. I know. It's important.
There's a lot of information on this. Yeah.
You know, that's why it's important. I know where you're at. I'm just saying it's important to review it before you come to class. You can't know it. Okay. I just said, just try to review it. I know where you're at. These are the last two classes that are the toughest. You are in the middle of the toughest classes of drugs because it affects the heart, the lungs, and the vascular system. And that's basically like 90% of the body, isn't it? All right. So lisinopril is your prototype. It is an ACE inhibitor, and its purpose is to reduce blood pressure. It blocks the release of aldosterone, which is on the RAS system. Most important thing, constant irritating cough. Dizziness, because of what's doing with the blood pressure, it's decreasing it, okay? Contraindicated in pregnancy and potassium sparing, okay? Drug interactions, alcohol is not a good thing. Okay, what would you do as a nurse? Yeah, I think, who was it? Megan said, watch them. Yeah, you watch them. You monitor their renal and function tests. This is a reason why, guys, that when you're working in a hospital, like every day they get their blood drawn, okay? Because they have to have those numbers. That goes back to what's normal. See if it's making a difference. All right.
You're not suddenly stop.
Right, yeah. Okay, these are angiotensin 2 receptor blockers. So these are known as ARBs. You have ACEs, and those end with what? Prils. ACE inhibitors end with pril. ARBs end in sartan. Okay, go back to that little picture I put online. It will help you tremendously. Okay, they act on the RAS system to block angiotensin 2 from the angiotensin 1 that are found in many tissues. They cause vasodilation and decrease peripheral resistance. Peripheral resistance is one of the reasons why people have hypertension. So if they can decrease it, and it decreases blood pressure. That's the mechanism of action. The ARBs do not cause the constant irritated cough that ACE inhibitors do, and they end in sartan. Side effect, again, orthostatic hypertension, dizzy, drowsy, and you do not use in pregnancy or heart failure. Here is our valsartan, but I'm not going to repeat because you'll review it, right? Okay, direct renin. Okay, so this is not one of the classifications, but it binds with renin, which comes out of where? The kidney. Renin comes from the kidney, so it binds with renin and causes a reduction of angiotensin 2 and 1 and aldosterone. So before it even mixes with the liver, it binds it so there's not as much coming out, so there's not going to be as much to convert. And aliskiren is the FDA-approved renin inhibitor. When used as a monotherapy, which means one drug therapy, it's not as effective in reducing blood pressure in who? African American or Black Lives Matters. Okay, so we've gone over several drugs that are not effective alone in the Black population. Now we're going to get to one that is effective as a one dose for Black populations because Black Lives Matter. Okay, all righty. So calcium channel blockers. You had a couple of those in last unit, right? What was the one you had? Yeah, diltiazem, right? Okay, and they're divided into 3 groups because they block which channel? Calcium. Yeah, they block the calcium in the smooth muscle cells because calcium flows in which phase? You were tested on that. Right. Calcium continues the contraction, right? It doesn't let it stop. It continues the contraction. That's why it's used in SVT, because you've got all these, these contractions that are just happening. And if you can just get it to extend a little bit. Sometimes the heart will restart itself. That's where adenosine comes in, things like that. Diltiazem is another one. It reduces the heart rate, but it can also be used as an antihypertensive. All right, so these are the three. These are your verapamil, your diltiazem, and your amlodipine, and your nifedipine. You'll see these a lot.
Very nice drugs.
Very nice drugs. Remember that picture? Yeah. Yeah, and these are the largest group of calcium channel blockers used to control. Okay, calcium channel blockers work the best to reduce blood pressure in African Americans when compared to others. That's important to know. Okay, so here they are. Okay, and what they work on. Okay, verapamil is used to treat chronic hypertension. It's not a really popular drug. Diltiazem is nifedipine, is the most potent of the calcium channels, and you'll see amlodipine prescribed a lot. All right. Now, I have a learning activity. Yeah, let's do it after lunch. Does that work? Your brains are like on overload. Like a half hour?
30 minutes. We still have my half to do, so we gotta get back on time.
Yeah. Okay, question? Question? You had a question?
This is only unit 10. We still have unit
Yeah,
11.
Megan, you had a question. Okay, you're stretching. Any other questions? Online. Online. No questions online. Okay, so we're going to pause the recording. So we will start at 12:25 on the dot, 12:25. It's a learning activity. It takes quick. It's like Jackbox, and it'll go quick. Okay?
Ready, set, break.
Ready, set, break.
I'm going to get lunch.
I totally would. I don't even care.
All right, we're 2 minutes away. So I'm starting to just kind of get this up. Hopefully it won't kick me out.
I'll drink like a gallon of water. It's like, I don't know why I didn't do this all day. But even if I don't, I'll still like, I always have my entire life like tested for diabetes.
All righty, so while we wait for one more minute, those of you that are online or those of you that are here, the learning activity is either using your phone or your computer. So there's no cost to this. We're gonna, if you played Jackbox before, have you played Jackbox TV before? So you can text 37607 and I'll give you the code response in just a minute. Or you can go to polev.com and then enter my first name, EVERE 759, depending on, and you can do that on your phone too, if you want to go to the web. Either way, it's either text.
You don't text the word code, by the way.
Yeah, don't text code.
Give us a code.
I'm gonna give you a
I just
code.
did the exact same thing, and it's like code capture out.
Yeah, hang on to the code.
And I bought the Munster DVD.
Oh, I meant you have it.
Okay.
The Munsters. Oh, it's like.
Oh, so looks like people have already taken this. You guys. All right. So here's the. So it's DEBORAH EVERE 759. That's the code. The 37607. Okay. So has everybody got this? Either go to pollev.com / then DEBORAH. That's my first name, Deborah Everett EVERE. Then 759. What this is like Jackbox, okay? So there's a question, and then you choose A, B, C, or D. And based on what you choose, this will formulate in real time what your choice was, okay? So here's the first question. A patient's admitted to ICU with increased intracranial pressure. The nurse would anticipate administering what? Yeah. So are we there? Okay, see, somebody responded. Okay. So log on, make your choice for this question. Okay. What? You just do one. Just do one. Okay. All right. So depending on how many people respond, we're going to get real, real data. Okay. So make your choice. What do you think? Very quick.
Obviously, people are changing their
I know. Don't change your answer. Just do one. Okay. Because we gotta get through this. So just make your choice. Just make a choice. It's just gut feeling. There's no right or wrong answer. It's just kind of review. Okay. It's just review. Okay.
Hey, Deborah.
Yes, I'm here.
I can't figure out, like, because I'm on my phone and all I'm getting is just a thing that says, I've joined this session. When I'm done, reply leave. I'm not getting any questions. I'm not getting anything. That's all I'm getting.
Okay. Hang on. Can you go onto the, are you on the poll Ev or are you on the text?
I'm on the text.
Okay, try the poll Ev on your phone. Can you do that? Or on your computer?
I'm just on my phone.
Yeah, so like, you're going to pull up a web browser, just POLLEV.com/DEBORAHEVERE759. What happened?
She's in the group, it sounds like. She's just not seeing the questions.
I just want to see if she sees the question.
Okay, that works. So basically, like, the text message way doesn't work.
Okay. All right. So everybody, so you can still use your phone. Just log on to the website then. And just quickly choose. So there's going to be a few questions. There's going to be like 17. And it just go your gut feeling with what we've gone over and what it means. Okay. So is everybody on board with that? Corby, can you check text the chat?
Yeah.
Okay, everybody good? We're good? Is it working? Okay, all right, perfect. Let's go with this. This gives us real time. So yes, the answer would be mannitol. Why? It decreases intracranial pressure. Okay, all right, here's the next one. Patients taking furosemide, 40 milligrams for heart failure and hypertension. It's most important for the nurse to assess the patient for the development of. I know. Answer. Just pick one. It's not hard. Okay, this goes back to your furosemide. This goes back to your slide. So it goes, potassium goes off, and what were the other two things that I said you need to know? Sodium and magnesium, and it increases the absorption of calcium. Okay, next one. Which statement will the nurse include when teaching a patient about loop diuretics? Take the medication at bedtime, take it on an empty stomach, rise slowly from a laying or sitting position, avoid fruits and vegetables. Just pick. Just pick.
Now you're ready.
Okay. Okay. Why is A not correct? Taking the medication at bedtime. Yeah, you're gonna pee. You're gonna pee all night. Okay, because diuretics get rid of the fluid. So yeah, and what's the most common things of diuretics that you need to watch for? It's called orthostatic hypotension. What is that? Yeah, when you get up. Okay. Patients receiving furosemide is most important for the nurse to monitor the patient for the development of. Okay, diuretics except for one are what? Potassium what? Wasting. So if it wastes it, what do you have? Hypokalemia. Okay. Next. Please answer. Patient, because this is how you get your participation points, people, because I can tell who's responded. A patient with congestive heart failure gains 5 pounds. It most likely indicates a fluid weight gain of.
It's kind of hard. Not exactly.
Okay. 2.2 pounds equals 1 liter. So 5 pounds is what? 2-ish. Yeah, 2-ish. Yeah. This is supposed to be fun, guys. Patient with chronic glaucoma is most likely to receive which drug? Ooh, do you remember that one? We talked about, there's only one that's really good for glaucoma. I know. She got to. So I'm trying to mimic what you're going to see on the exam, okay? And it is a carbonic dihydrase inhibitor. Okay, good job. All righty. Okay, blood pressure is 142 or 82. Healthcare is prescribed a diuretic. The nurse knows this blood pressure is.
I forget already.
It's okay, just do your thing. Okay, so again, these review questions are going to help you on the what? Exam, okay? And they're going to help you in your nursing practice, okay? So remember we talked about how systolic has a greater indication than diastolic. So what would you put? Stage 1. Okay, here we go. Patient receiving angiotensin 2 receptor blockers. Which does the nurse recognize as an angiotensin receptor blocker? What's the last name? Last name of ARBs. You see? What's LOL? Beta blockers. What's Pril? ACE. Okay. Amlodipine. Calcium channel blocker. Valsartan. ARB. Good job. Okay. Patients receiving angiotensin receptor blocker, an ARB, is most important for the nurse to assess for. Just answer. Just put your answer in. Okay. Please put your answer in because I want to give you all these points. I know you don't also necessarily know all the things, but what's the most common one you would think matters? Because it collects the data. So I go back and I look how many responses are.
You can't tell who's on what phone or who's.
No, but I can tell how many people replied.
We have your phone number. So.
And we have your phone number. So it's dizziness, right? Because it drops the blood pressure. Okay. Instructs the patient not to suddenly stop taking antihypertensives in order to avoid what? Rebound what? Right. 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 Good job. Okay. Rebound hypertension. Do not stop abruptly. That goes for clonidine too, guys. Goes for clonidine too. You do not stop abruptly. And I just got in trouble because I gave you an answer. A patient with hypertension is ordered to receive an ACE inhibitor. Identifies the most common benign side effect of this classification is?
The only one I knew before you gave me the
Good job. Did you put it in? Has everybody got that? 100%? All right. Next one. Before administering the alpha-adrenergic blocker prazosin, it's important for the nurse to assess the patient history for a history of. Take a guess. It's an antihypertensive. Renal disease. This is contraindicated. Okay, I know. Patients prescribed a non-cardioselective beta blocker. Okay, that should ring some bells in your head. What nursing intervention is a priority for this patient? A non-cardioselective. Yeah, auscultation of lungs. Okay, because if it's non-selective, then it affects what? Both. Okay. Good job. Calcium channel blocker has been ordered for a patient with hypertension. We're going to perform the Heimlich maneuver here on Kimberly. Which condition in the patient's history is a contraindication to this medication? What does a calcium channel do? Okay, so if it's been ordered for a patient with hypertension, what is it going to do?
Lower.
It's going to lower the blood pressure. That's the whole purpose of the drug. So if the patient has hypotension, would that be a good thing to prescribe?
Bring it all the way down.
Okay. What is a priority nursing diagnosis for a patient taking antihypertensive medication? This is a great NCLEX question. These are nursing diagnoses.
I was scrolling and I hit the wrong. I think you can change your answer.
Yeah, can you change it? I don't know.
Now it's not letting us.
Okay.
No, never put it on.
Okay. Ooh, so we've got knowledge, we've got fatigue, we've got alteration in comfort, and we have alteration in cardiac output. Why would A be correct? Why would A be correct? Say it. Okay, and what is cardiac output?
How effectively
It's circulation, is it not?
The blood.
Okay, ABCs. On the NCLEX questions, it's always airway, breathing, circulation. Circulation outranks fatigue, it outranks knowledge, it outranks comfort. Okay, caring for several patients who are all being treated for hypertension. Which patient gets the assessment first? This is an NCLEX question, NCLEX type question. Okay, why would A not be correct? Okay, they've only been on it for a day. What about a beta blocker and a thiazide? Why would that be not correct?
See what I did? I was like, B and D are pretty similar, so I was like, well.
Okay, same thing because beta blockers and thiazides are prescribed all the time. Yeah, that's normal. Say it. Be strong with it. Okay, but a patient who stopped taking their beta blocker because of cost, what's going to happen? Yeah, you got rebound. They got to get it first. Patients who's taking a beta blocker and Lasix, that's a diuretic. It's not a thiazide, but it's a loop diuretic. It's the same thing as B. You're right. Okay. All right. And we will, an ACE inhibitor, the patient plans to contact the healthcare provider if the patient is also taking which medication? So the patient's taking an ACE inhibitor and they find out that they're taking another medication that is contraindicated with an ACE inhibitor. Yeah, it's spironolactone. Okay, all right. Yeah, we remember talking about it. These are review questions, people, just like what we did. Okay, here's an ACE inhibitor, develops a non-dry productive cough. What is the nurse's priority? What would you do? But it doesn't help it. Okay. So an ACE inhibitor, a cough never goes away. So what's the only way to address this non-productive cough if they can't tolerate it? A different medication. And remember, antitussives are for a whole different.
Antitussives are for coughs due to sickness.
Oh, duh.
Yeah.
God.
Not as a side effect. Okay.
You've got the cold and you have a cough. You have a flu and you have a cough. You've got pneumonia and you have a cough.
Right.
Okay.
Drug. Change the drug.
I think somebody just said something online. Go ahead, say it. No? Okay. Patients carrying hypertension prescribed a clonidine transdermal patch. What's the correct information to teach this patient? Change the patch daily. Remove it before you're taking a shower or bath. Do not take any other hypertensive medications. Get up slowly from a sitting position. These are questions like you'll see, guys. Yeah. How long can you wear a clonidine patch?
7 days.
7 days. Okay. Do you have to take it off? I know. I'm giving you hints here. All right. Okay. Getting up from a sitting to a standing. It's that orthostatic hypotension. How many times have I said that? It's important. Okay. Statement indicates the patient needs additional instruction about hypertensive medication. Check my blood pressure, include rest periods, change my position slowly, will not mow the lawn until I see how this medication makes me feel. I'll take it when it's over 140 over 90.
Correct. Needs additional instruction.
Yeah, needs. That's what I'm saying, guys. Look at the question. Read the question carefully. That goes for your exam, okay? I'll only take it when I need it. Nope, they need more education. Prazosin, 140 over 90 is complaining of swollen feet. What do you think as a nurse would be the best action to take? Hold the medication, call the provider, determine how long they've been taking this medication, weigh the patient. Ooh, this is a good one. What do you think? I know you don't know prazosin. It takes upwards of 4 weeks to get therapeutic effect. So now that you know that, would that change your answer? Okay, what would you change it to? The 68%. Determine the patient's history. Okay? Alrighty, we're done.
You're going way too fast for me, Debbie.
Hey, we got places to go, stuff to do.
Real quick, are you able to go back to, I think, the first
Let me.
the second one where it talks about furosemide and the
Oh, sweet. You can go back.
electro.
Sure. Like the hypo.
Yeah.
Let's see.
The
Hang on.
electrolytes.
Oh, sweet.
I don't have history at the top.
Hang on.
Oh, go to the bottom. Go
That one?
There you go.
Yeah.
On the very, very bottom.
All right.
I'm like,
Corby's talking. She's got the floor.
Sorry.
I was wondering, I don't know what they said. There was just, Hannah online had a question about this.
Okay. So what's your question, Hannah?
Low serum, because it's, is it B? Is that the answer?
I believe B was. Hang on. Okay, so why would B be correct or incorrect? Go back to your slide. Hang on. Somebody talk online.
That is the book, and it says furosemide causes hypocalcemia and it causes
Hypercalcemia, right. Yeah.
It causes hypocalcemia.
So
The dilute diuretic.
So A would be low serum potassium, low sodium, low magnesium, elevated calcium.
No,
It says low. Okay. So then B, it would be B. B is correct.
Dilute diuretics get rid of everything. Think of it that because it's furosemide, that's the fastest working. If you need quick diuresis, that's what you're gonna go to. So just think like your body's not gonna have time to regulate anything. It's just gonna get rid of everything.
Which was
But that's also saying that elevated magnesium and calcium. We just determined that that's not right.
Oh, sorry,
So
I
it's
didn't
not
see that
low.
elevated. So it'd
Low.
be
Yeah.
C then.
So best case scenario, you're gonna have
Yeah.
low potassium sodium with remaining that, but it's gonna dump everything.
Yeah.
Right.
Yeah.
So C, because it's potassium, sodium, magnesium low, and calcium, based on your book.
Which was the one that elevated calcium?
That's the potassium sparing diuretic, spirolactone, because it keeps the potassium. It doesn't waste it.
No, the calcium. Calcium. Like, there was one of them that excreted everything, but it elevates your calcium.
I think that's spironolactone.
Yeah.
I couldn't remember.
Yeah. It is on your slide and it is on your prototype. So that information is there. Last thing. So if somebody's coming into the ER, okay, and they're wheezy and their lungs are junky, and they've got 3-4+ pitting edema, okay, and they've got huge hypertension. What do you think on a diuretic, which one would you choose to get that fluid off quickly?
I mean, I'm not wrong.
We don't have intracranial pressure and we don't have glaucoma. We have edema. We have overload of fluid. Which one gets rid of it fastest?
The one closest to the glomerulus.
Right. Which closer than that? A loop diuretic. What do you think that's going to be? Furosemide. And that's going to be IV. And we're going to give it slowly because we don't want the patient to become deaf. Yeah. I know, you can give them tinnitus if you give it too fast. So if it's too much of a dose, PO, their ears will start to ring.
By the way,
They're very rarely used.
that's what I said.
Yeah, they're very rarely used because of how much
Hey,
they ship.
Debbie,
Yes.
is there a way that we can look at these questions, like to review them and just study them?
You can, you bet. Now, I make a disclaimer here, okay? These questions came from the resources that are in your book, meaning you can go to the student resources and it has like test questions and it comes directly from your chapter. So yes, I will put up this PowerPoint. I will put it up right after I get done here in 10 seconds, and you can have that to study for it. There was a person who said to us, they've expressed us, they're like, we just need more help in kind of how the questions sound on the exam. And so that's what I'm trying to do, is address that need to have questions that you're going to see on your NCLEX and that are related to what we're talking about. So if there is a little, glitch of what I said was wrong in this recording, these questions directly relate to your book. Does that make sense? So you can find the correct answer. If I said it incorrectly, yes, I'm human. Yes, please give me a little bit. But yes, I will put it up so you can study these, okay? Did you feel like this learning activity was helpful? I know it's huge amounts of information. Your brain is exploding. Did you think it was helpful?
Yes. I'm trying to actually read the question and answers. Yes.
Okay. No. Someone said no.
Yeah. I too fast and I don't feel like I really absorbed anything.
Yeah, I feel like it was way too fast. Like I would have learned a lot from it, but I didn't even have time to like read the question and process the answers.
Okay.
So I was just like, oh my gosh, what is happening? I have no idea. And I just like randomly picked whatever so I could like catch up.
If you think these questions are valid, then we'll do this again and again. I can put it up, but see, if I put the PowerPoint up, because it interacts through the internet, and so if I put it up before, then it like screws it all up. Does that make sense? So I'll put these up after we do it. Is that a fair trade?
Yes.
Okay. All right. Okay. All right. That's what we'll do, and then I'm going to close out this recording. And Corby's going to take the next unit, which is the rest of chapter 39 and 13 and 41, anticoagulants. Anticoagulants. Now, I just want you to know on our test bank or test blueprint, do not go with like, oh, well, I don't need to study anticoagulants. You do, because you will use them every single day in your nursing practice. Okay? Does that make sense in terms of the amount of questions that are asked on the unit exam? Does that make sense? There's going to be questions, but it's more important that you know, ooh, this is really scary. Oh, sorry. So sorry, guys. It's really important to know anticoagulants in your nursing practice because you will use them every single day. Okay, any other questions? Shelby's typing something. Okay, Shelby, go ahead. All right, she's typing. All right, we're waiting for Shelby. Must be a great one because she says, I'm not trying to sound rude in any way. Right there, prefaces it. Okay. Say there is information that you tell us isn't actually correct on the PowerPoint is wrong. Will that information on the exam be coming from your PowerPoints or from the book? That is where I get concerned. I understand and I appreciate it. I'll let Corby answer.
Okay. Do you guys remember not even very long ago when we had the test questions about the inhaler? Do you remember that? That was like what, last week?
2 weeks, yeah.
Right, and the test question said to inhale quick and deeply, but we taught that you inhale slow and deeply. What did we do with that question? We threw it out. That's what's going to happen. Okay? So that, Shelby, that's actually already happened, and that's how we remedied the situation. So if it happens again, we'll do the same thing.
Yeah.
By like one of our attention, a student came to you and said, hey, this is what I studied, or this is what
Yeah, if
Right.
it's wrong on our
If it's
PowerPoint,
wrong, we'll change it.
and the test question directly reflected that, or the opposite or whatever, we'll address it. We'll throw it out. We're not going to hold it against you if we taught you wrong.
And that's why I said it's like, we're all human. But please understand that as we generate these PowerPoints, they're coming from your book. So if it is, a question, look at your book and then say, okay, on your PowerPoint, you said this, and we'll say, okay, then it's this. We'll put it in a clarification document. We'll make sure it's gone over. And if it is wrong on the test, we'll get rid of it.
Shelby, that's exactly what happened. A lot of people, most of you guys got that question right about the inhaler.
Yeah.
I think there was like 70% of you or 80% of you that got it right.
It was over 80%. It was 86% that had it right.
But we still threw it out because it was wrong. It was a wrong answer, even though you guys got it right. It was probably the most right of all of them, but still it wasn't what we said.
Right. So that was an error on the test. We took care of it. You got it. It increased your percentage. Because there were some people that got like 104%. Okay. When we threw out the 3 questions, it put them above 100%. Does that make sense? So some people rocked this last examination, not the one you took today, but the one a week ago, like rocked it over the top. Does that make sense?
So I hope that helps put a lot of your minds at ease a little bit, because we do.
We try to get it right.
We can make mistakes, but if you're at hour 0 and you're going to take your test and there's some kind of discrepancy, always go with your book. Okay.
All right. Anybody else online? No? Yes? Is anyone there? Okay.
All
right.
No.
Okay.
Nobody's there.
No one's there. All right.